Thank you for joining us today on this continuation of the lecture series for urinary system pathology. Today's lecture will be about obstructive nephropathy. There are multiple things that can cause obstruction to the kidney. We are going to focus today mostly on urolithiasis. Again, as I mentioned, there are multiple things that can cause obstruction in the kidney, be it from lymphoceles, abscess, ureteral necrosis, just anything that can block the urinary system can cause obstructive nephropathy. But today we're going to mostly focus on the kidney stone urolithiasis. So kidney stones are hard masses that develop from participate from the urine, and it's typically going to be made up of calcium. Depending on what the stone size is, the different outcomes will be apparent. Very, very small stones are able to easily pass through the collecting system and out the urethra. Larger stones are going to start to get stuck maybe within the kidney, within the ureter, within the bladder, and get stuck somewhere along the way and start to cause obstructive problems. And then very large stones that fill the pelvis are going to be called staghorn calculi, and those are going to need surgery for removal. Stones in general are more common in men, and once you have a stone, you're more likely to develop more of them. When we are evaluating for ultrasound or stones by ultrasound, it actually is kind of difficult. And that is because there's just so many other things that are happening in the kidney that can kind of catch our eye and resemble the echogenic border of a stone. We can have prominent renal fat. There can be mesenteric fat if we're trying to look for a stone somewhere within the ureter. The arteries of the kidneys can calcify, and those can kind of look like tiny stones. So unless a stone is producing very obvious, evident acoustic shadowing, it's going to be very difficult for us to differentiate stones from other materials in or surrounding the kidney. Another thing that we can try to do with our ultrasound machine is to use color. There's something called a twinkle artifact, and it's just kind of the way that sound interacts with the crystals of the stone that it produces this extra ringing, which looks like noise. And so you'll get, let's draw. So here you have your stone, and then we put our color box on, and what you'll get behind it is all this twinkle artifact, we call it. We'll see all this like little noise behind it. And so that can kind of help to, if you have a radiologist that agrees with the twinkle artifact, that'll help you to help diagnose a stone within the renal system. So kidney stones on ultrasound appear a lot like gallstones. They are very echogenic. If they are large enough, then they should have a nice acoustic shadow behind it. Make sure that you have your system settings appropriate, that you'll be able to pick up that shadow. There are lots of systems like spatial compounding. That's usually on whenever we are scanning. That spatial compounding's job is to get rid of shadows, and so the shadow might not be as obvious if that system setting is on. So if you have a patient coming in to check for renal stones, make sure that you are adjusting things using different frequencies, using harmonics, fundamental, take off that spatial compounding, and see if you can produce a shadow from a suspected stone. We mentioned those staghorn calculi. Remember, they are really highly associated with the xanthogranulomatous pyelonephritis. So, but here we have one, we can see the very anterior border of it, and then just like bones, we get lots of shadowing beneath it here. So that staghorn calculus fills in the whole pelvic area. And here's an example of one. We can see them on x-ray. Just like we can see bones, we can see the staghorn calculi. They take on a really interesting shape. They take on the shape of the renal pelvis, so that's very interesting. And then we have the gross anatomy of one. Again, these are not going to pass. They're going to cause a lot of problems for those patients, and they're going to be in a lot of pain, and they're going to need surgery to get rid of those. So that is really kind of it for stones. We're going to get a lot of requests to look for stones, or what I feel like I see more often now is that maybe a patient had stones, they know they had stones, so they got their CT, diagnosed with stones, and then they had some sort of treatment. Maybe they did lithotripsy where they blasted the stone with lasers, or maybe they just were expecting the patient to pass the stone. And then, so like 2-3 months later, they'll send the patient in for an ultrasound to look for stones. And again, we aren't very good at seeing stones unless they cause that shadowing, because there's just so many other things that we can kind of be like, well, that might be a stone. I don't know. So the nice part is that if that stone is causing problems, it's going to cause hydronephrosis. So if we don't see the stones and we don't see hydronephrosis after confirmed stones from a CT, then they're probably not going to be causing the patient any problems. And if that patient is still having pain, they're going to do another CT and try to figure out what's going on with the stone. So remember, we're not the end all be all for imaging. Stones just aren't really our jam in the kidney, but we can definitely give it a really good try. If they're big enough, we'll see them. That brings us to the end of the obstructive nephropathy. We have only a couple more left in this series. Our next one will be bladder pathology.